All right, guys, let's get busy talking about grief. And when we're talking about grief in the context of step one, we love to refer to the Kubler-Ross model. That may be a hot word you see on the exam. And classically, grief is going to be split into 5 different stages. And these stages can actually occur in any order. And so let's talk about each of the stages, but we're not going to expect them in any specific order. So denial would be when patients do not want to even accept that their loved one has died. When we're talking about anger, patients may be angry at the universe or the God they worship, or maybe other people in their life who may have been responsible for a death of a loved one. Next is bargaining, and bargaining is when patients say, I will do anything to have my loved one back. I will pay infinite amounts of money. I will do community service. I will pray 1,000 times a day. That is an example of the bargaining stage of grief. Next, we have depression, where it is characterized by intense sadness, and we'll cover some of the other depressive symptoms a little bit later in a minute. Then we have acceptance, which is kind of where patients have been through one or more of the stages of grief. Patients are starting to accept that their loved one is gone and is not going to be coming back. Now, let's talk about some of the symptoms and natural course of grief that are kind of associated with the depression and anger. So patients can experience things like shock, restlessness, and anxiety, as well as guilt that they may have had some sort of responsibility for their person's death. Additionally, they're going to have feelings of yearning and sadness, and these are all things that we naturally expect in someone who is grieving and are pretty natural to identify in a question stem. Also, patients can experience transient somatic symptoms. These are usually quite nonspecific, but they are not of concern. Now, I want you guys to really focus on these last 3 bullets that I'm going to highlight in red for you because I think these are the highest yield sticking points that patients can experience and get asked about on the exam. So first, let's talk about visual and auditory hallucinations. It is extremely common for grief to be described as patients who have dreams about their loved one coming to them and speaking to them at night almost as if they are an angel. They will hear voices of their loved one. This is completely normal part of grief, and it is not concern for psychosis or psychotic behavior. So that is something to be on the lookout for. Additionally, suicidal ideation is not a normal part of grief. If you have a patient who is grieving in a question stem and they express suicidal ideation, they need further workup for suicide risk, and that is super, super important. Additionally, grief lasting longer than 12 months is no longer called grief, but it is reclassified as persistent complex bereavement disorder, and that's going to require additional therapy on its own.